The world for colon cancer is clearly changing. We know sidedness. We'll need to figure out what that's all about, because that's clearly some sort of molecular interaction. My hunch is it may not have anything to do with us. It might have to do with our microbiome, the bacteria that live in our GI tracts and are such an important part of our health that we really don't understand yet. So us and others are working hard to study the microbiome to see what its impact is on colon cancer and why it might be different. Precision medicine's having a positive impact. We know now how better to pick which patients for which drugs. And so molecular profiling is becoming part of the standard of care of treating metastatic colon cancer, and we have therapies to go along with that. Immuno-oncology, the same. We are working to try and expand the number of patients that are eligible for that, but we have to continue our aggressive approach but cautious approach as we move that forward. I think one of the biggest areas of research that we have only just started to jump into is why are all these young people getting colon cancer? I saw an 18-year-old this week with colon cancer. Why is this person getting that disease? Lots of people in their 20s, 30s, and 40s. And I'm really sort of unhappy with the societies that said, oh, we'll just start screening at 45. That doesn't do anything to solve this problem. And it is a true epidemic, and it's not just the United States, and it's around the world, and it's not fat people who sit on their couch and eat Big Macs all the day. It is actually very fit people who are doing all the right things who are getting this disease. So we need to figure out what's going on there. And my hope is that whatever answers we learn there will in fact apply to much larger populations and have a significant positive impact for patients in the future.
I'm not sure any of the novel combinations are really going to change the game. Certainly many of us have gone to the FOLFOX series, the four-drug combo chemotherapy, with or without the biologics. I think one thing that I could say is that we probably have made mistakes along the way in terms of just mixing and matching chemotherapy. Many of the studies, my study included, just assumed that chemotherapy was indifferent to the effect of the biologics, and I'm not sure that that's right. In fact, probably that's not correct. Now, do we go all the way backwards and start from scratch? Probably not. But I think it's fair to say that the best combination for a given patient isn't necessarily going to be FOLFOX-based, which is how almost everybody's treated in the U.S. It may very well be FOLFIRI-based or some other base. It's hard to revisit that, though. So the truth is, knowing what the best new combinations will be really will depend on figuring out either how we can overcome resistance, or, for example, if our explanation of sidedness turns out to be accurate, where, let's say, a VEGF inhibitor such as bevacizumab might be extremely valuable on right-sided tumors, that might be something to think about. If you think mechanistically, we have some data in our 80405 data set, although small numbers, that the MSI high patients get much more benefit from bevacizumab than they do from cetuximab. So you can imagine combining bevacizumab with a checkpoint inhibitor, for example, to see if you can magnify the effects. Those seem reasonable studies to do, but really, in terms of much else, we're really waiting for new molecules and new targets, and we're waiting and waiting and waiting. I think the other thing we're hoping for is that some of these new vaccine strategies might work, because with the checkpoint inhibitors, I think vaccines have much more of a role than we've thought of. So we've got an active program there as well, but so far it's mostly wishful thinking. The way I put it to patients, unfortunately, is we're optimistic about these treatments until we're not optimistic about them. Obviously, if we're going to make progress, one of the things we really have to do is put patients on clinical trials. We have to collect data on all of our patients, and so I think everybody, even in the absence of great ideas, I think at least even collecting the information and following our patients to know who we help and who we don't help is important. And what my own view is, every patient should be poised to go on a clinical trial, certainly at the time of refractory disease. That does mean, in many cases, that we will favor a study rather than, let's say, regorafenib or TAS-102, just because we feel that we want the patients to get the option of the checkpoint inhibitor. I think really the advances are going to require new drugs or new targets that we just don't know about right now.